I'll hand you over to Chris for the next session, which is the question and answer.
Thank you very much, Beverley. So we're able to take questions if you want to post them in chat. And there is a kind of panel of people who are involved in research in these areas who are who now joined the meeting, and we can go to them. So nearly every area that we covered in the checklist is covered by someone on the meeting. We have one question about local authorities and health boards. Have they signed up to use this checklist? I'm just going to ask Hayley Crawford, who's at the University of Warwick, whether she can just say something about work going on to make the checklist more widely available. Over to you, Hayley.
Yeah, thank you. Yeah, it's a great question. So we, in the last year, have received funding from Great Ormond Street Hospital Research Charity. And with that funding, we're conducting a project that incorporates some patient and public involvement to ensure that the checklist meets the needs of various different individuals and stakeholders. And then we're going to be piloting how we can use that checklist in clinical paediatric appointments. And that's specifically with Birmingham Community Healthcare Trust. So it's local at the moment. And that will take, we envisage around 3 years to get some really high quality data on what we need to do to roll this checklist out in that sort of clinical setting. And then we'll be able to take that hopefully even further in terms of the rollout. So at the moment, the onus, I suppose, is on the parents to complete the checklist. But what we're working towards is parents being able to do that, which is why we've released this with Cerebra. And then parents can show that to the healthcare professionals that they work with. The idea is that this is not necessarily just paediatricians, although those are the people we're working with at the moment. It could be a range of different healthcare professionals that you see with your child or the person you care for.
Thanks very much, Hayley. There's a question from Nigel over. Nigel is the CEO of the Smith-Magenis Syndrome Foundation, and it's echoed by Dawn Pickering. I think Dawn is a researcher in South Wales, sorry not to be more specific, Dawn, whose kind of main interest, I think, is physical disability. And Nigel's question is about the emotion dysregulation, and he's saying where in the checklist is joy and overexcitement, and in a way the kind of initial response to that is, well, that's a great thing, but of course, as Nigel then points out, well, for some people the overexcitement and wanting to go out, for example, wanting to go out on a special activity with a preferred person, having that strong emotion and looking forward to that, if that then can't happen, or there's a drift over into a kind of a different kind of emotional outburst, then the person is denied that. And I think that's a really interesting point, in that we have indeed focused on negative aspects, if you like, or what we call the negative valence of the emotional states. But there is a kind of important point there, and I'm going to see if Kate Woodcock from the University of Birmingham might be able to take that question. Kate's running with Justin Chung, a really interesting program of research into emotional regulation, but also into some of the cognitive problems that might trip those emotional outbursts. Do you want to comment on that, Kate? I can see you've got your mute button on. Is that a way of saying you're not available?
No, I can comment.
Thank you, Kate.
Yeah, so one of the things we've been doing recently is talking to parents and caregivers of young people across a range, who have a range of different diagnoses, who show emotional outbursts. And I think it's sort of consistent with what you were saying, Chris. There are examples that caregivers have identified of where you can get sort of a very positive emotion that can tip over into an outburst that then ends up looking like a negative emotion for people observing the outburst. But I would definitely say that we don't know enough about the positive aspect, and it's something that anecdotally I've observed, for example, in individuals with Prader-Willi syndrome who have a lot of emotional outbursts, in like on average, that you commonly see these really positive emotional episodes. And yeah, so basically I would really like to look at that in more detail, but I think at the moment we just don't know enough. But I think it's all part of this sort of emotion deregulation, if you like. Hope that.
Yeah, thanks, Kate. So that's a good pointer for us, and tells us some way in which we, when we take the checklist to people, we might then modify it in the future. And just a reminder that the survey that's been set up at the University of Warwick, I think there's a link posted in chat. If not, perhaps Beverley could post it again. And Hayley Crawford and Hayley Trower at Warwick University will take those comments that you're making and feed them into the work led by Hayley Crawford at Warwick. Just while you're there, Kate, there's another question from Rachel about her son going from being fine to having meltdowns, not able to use coping strategies because the time to intervene is missed. And I know in your PhD work you looked at sequences of behaviour leading up to the meltdowns, but also how some practical strategies that might help there, if I remember, with Leah Bull at Great Ormond Street. Could you say something about that? You're muted, Kate.
Yeah. So, sorry, I was just looking to see if I could see that. So the question is about the outbursts
10:31 a.m. Yeah.
Oh, I can't see it, but sorry, is it just the questions about
So it's about my son has started going from being fine to having meltdowns, resulting in me not being able to use his coping strategies. So he does have these strategies, but as the time to intervene is missed. This can be when he's angry, upset, to him being really happy. What can I do to help him? So it's about that window.
Yeah, so like the sudden onset of the behaviour. I mean, in the briefing document that we've written in collaboration with Cerebra, we've got a section in that talks about trying to I guess use coping strategies and identify subtle changes in behaviour, but I completely appreciate that it's really, really difficult because one of the characteristics of outbursts is that they're such sudden onset. So what we have done in the past is some sort of, well, we've done observational studies where we've observed individuals and tried to identify the kinds of really subtle behaviours that you'd see. So I don't know, for example, sometimes it's just a change in eye contact. But I think those are the kinds of things that as a caregiver you can identify, but it might just be that if the nature of the outburst has changed quite recently, that you just haven't been able to identify those yet. But I think from speaking to parents, for most people do say that they can identify just those sorts of subtle changes in behaviour, but it just perhaps might take a bit longer to sort of get a feel for that signature, if that makes sense. We haven't ever recorded those kind of things in a diary, but we have used diaries before of outbursts, which several caregivers have found useful, just in terms of thinking back afterwards, because people often say that everything happens so suddenly, and so yeah, okay, you're not going to be able to write it down immediately, but even if you wrote it down, I don't know, at the end of the day or whenever the next time is, a lot of caregivers have said, oh yeah, just doing that sort of exercise of reflection has helped me to find patterns that I didn't notice before. So it might be useful. I mean, I don't know if you've tried that, but it might be useful to just with whatever time you've got, just make a few notes about what happened, and if there are any of those subtle behavioural changes that you might have identified beforehand, to try and get over the suddenness.
Thank you, Kate. Just a couple of things coming out of that conversation with Kate. I think the first thing is the point raised by Nigel Over, the CEO of the Smith-Magenis Syndrome Foundation. And there, I think in people with Smith-Magenis, that particular syndrome, you do see this strong, positive, emotional response that, for example, we wouldn't see in people with Prader-Willi syndrome, where the emotional response is often quite different. And the point there is that it is then important to know the cause of intellectual disability, because it does influence the checklist item and what you would look for. And we are currently working on modifying the checklist so that the checklists are syndrome sensitive. So we have their information that is targeted at that particular people who have that particular syndrome. The second thing Kate mentioned there was the emotional outburst information document available from Cerebra. I think that's now available online. If so, then perhaps someone could post a link to that, and maybe links to the page on which the other guides are held. I think the guides are really useful summaries of where we're up to. I'm going to ask Caroline Richards from the University of Birmingham and part of the Cerebra network if she would pick up a question posted by Maya Jackson at about 10:29 a.m. to be precise, about a learned behaviour and how that behaviour is managed in school. And of course, it's always very difficult to be able to give advice without having met children and talk through more precisely with people. But maybe there are some general kind of principles that Caroline can point us to. Over to you, Caroline.
Yeah, absolutely. Thanks, Chris, and thank you, Maya. That's a really helpful question. And as Chris sort of mentioned, this is not uncommon for children to show different behaviours in different contexts. And actually, it's not uncommon for any of us. There are different rules that kind of govern our behaviours at home, at school. We learn to act in different ways in different contexts because of how the environment around us shapes that behaviour. But it is really difficult when you've got a child who's presenting very differently at home or at school. I guess from what you've said about this specific kind of context for your son, it sounds like there might be some functions you're identifying, some triggers to his behaviour. And if that was at home, perhaps you would use some of the checklist items to think through, are there ways I can change the triggers or change the way that he responds, teach him a new way to communicate, maybe that he needs a break, or to communicate that maybe he would like to have someone's attention to play with them. But I think probably first and foremost, where I would start in a context where behaviours are very different in different places and where they're being responded to in very different ways, is actually about trying to get that partnership established with the school or with the nursery, whatever that other context is, because the more patterns are kind of repeated over different contexts, the more we respond to behaviours in the same ways, the easier it is for children to learn that those behaviours should or shouldn't happen. And the easier it is for them to learn new behaviours that might be a better way of communicating their needs and preferences. So really what you want to have is a situation where at school, as far as possible, behaviours are responded to in the same way, but also the kind of contexts that the behaviours happen in are broadly as similar as possible. So what you might want to do is actually try and have a kind of link with the school, whether that be through the Senko, whether it be through a one-to-one help for your son, or in some special schools there will be members of staff whose specific focus is behaviour, and actually working very closely with them to make sure you're gathering the same information so that you can identify what those triggers are, and so that you're agreeing on a behaviour plan about how you all collectively will respond to those behaviours. I guess the main message I'd want to say is that the things your son might be communicating through his behaviour, whether that is that he'd like some more attention or whether it's that he'd like a break, those are very valid preferences and needs. And I guess the focus hopefully will be on finding alternative ways for him to communicate that across contexts.
Thanks very much, Caroline. While you're on, I just wonder if I could ask you to say a bit more about the program of sleep research, and maybe Georgie Agar would comment on this as well in a second. And I just it seems to me and many other people that sleep problems are actually just almost accepted, or sleep difficulty almost accepted to be part of an intellectual disability or being autistic. And what are the main sort of sleep problems that we see, and the main, just an overview really of what sorts of interventions might be possible?
Yeah, okay. So it's a massive question, and I'm not going to talk for very long. I'm actually going to ask both Stacey and Georgie perhaps to unmic, because I think they are here and effectively they lead this work at Birmingham for us. But I think the key points I'd want to say is that, as Chris said, sleep is a very neglected but incredibly important cause of all daytime functioning, whether it is our well-being or whether it's our behaviour. Actually, for typically developing individuals, we now recognise this as possibly the most important determinant of what happens during the day. So we should expect for children with a learning disability that this is a critical area for us to understand and get right. At Birmingham, we've been trying to do a few things. So we've been trying to more accurately describe sleep problems. So when a child's awake or not sleeping during the night, there are different ways we can assess that. But in general, in learning disabilities, we've tended to simply ask parents to fill in diaries, to fill in questionnaires. And what we're doing there is asking really super tired parents, oh, when your child woke up for the 10th time last night, was it for 6 minutes? Was it for 8 minutes? Did they snore a little bit? Did they jerk awake? And as exhausted parents, that's really hard to measure precisely. So one of the things Georgie's been pioneering is alternative, more objective ways of assessing sleep. And then from that, we're trying to look at what Chris mentioned around kind of cause being important. So whether there are different profiles of sleep difficulty in different groups. So sleep sounds very generic, but there are actually different disorders of sleep. And all of those will have unique treatments. In terms of intervention, it's quite possible that we don't need new interventions for children with learning disability, but what we need is to better understand what the potential cause of a sleep problem is. Is it pain that's causing waking? Is it restless leg syndrome? Is it insomnia that's linked with kind of reinforcement or learning cycles at home? And then that can help us to tailor our intervention approach. So we're also doing some work to look at that kind of assessment, triage and intervention. Georgie and Stacey, what have I missed?
I mean, I think that was very comprehensive, Caroline. Yeah, the only thing I was going to say is that I think you've touched on it already, but sleep not being kind of one thing. So thinking about different aspects of sleep that might be more difficult. And actually, we don't at the moment have a huge amount of particularly robust evidence to help us unpick that in people, particularly people with severe intellectual disability, because some of those techniques that we would normally use really just aren't accessible. So what we might want to do for children that don't have a learning disability is let them stay overnight in a hospital hooked up to lots of different wires and study their brain movements, and that just might not be something that's okay for some of the children and adults that we work with. So we are sort of looking at trying to do more objective measurements in the home, in children's kind of habitual environment. So that's some work that Stacey and I have been doing. But you as a caregiver, if you're here as a caregiver, the first thing you could do that would be brilliant is just keep a simple sleep diary. So that can really help us to unpick some of the different aspects of sleep. So things like children waking at the same time. Generally, it doesn't have to be really precise. We don't need to know that it's 6 minutes or 8 minutes to start with. But if you could just give an idea about how long it's taking children to fall or adults to fall asleep, how many times roughly are they waking, and that can really help us to sort of work out what the likely specific problem is to start with. So if you're concerned about your child's sleep, I'd really recommend doing that. There is a sleep diary in the Cerebra sleep guide that's just an example. It doesn't have to be super fancy, but there's a kind of an easy one in there for you there. Would it be possible to have my email? Yes, g.e.agar@bham.ac.uk. I'll add it in the chat, but very happy to kind of pick up additional questions. I don't know if you wanted to say anything.
I was just going to comment on additional work that we're doing going forward. So we do have quite a robust protocol now where we've developed a mobile app where we integrate a sleep diary, and we're looking at the profile of sleep across different syndrome groups. So Georgie's work highlighted that there are syndrome-related differences in terms of the profile of sleep difficulties, and going forward, Rory O'Sullivan, who's the Cerebra funded PhD student, will be extending that work using our tried and tested protocol in other genetic syndrome groups, looking specifically at sleep, and also going forward as part of our work considering some early intervention, particularly in syndrome groups where we've already established the profile of sleep. So yeah, watch this space.
Thank you, Caroline, Stacey and Georgie. That's the sleep team at the University of Birmingham. They're doing some kind of really remarkable work there, and attending to such a fundamental quality of life issue as sleep that's been neglected for far too long. I'm going to ask Jane Waite if she would say something about anxiety in people who with severe intellectual disability, and particularly those who have poor expressive communication. Just before I come to Jane, there's been a couple of questions in the chat or comments in the chat about, is this, how does this compare with other checklists? Can this be used in annual health checks? Would we develop it for people with other characteristics, for example, a less degree of intellectual disability? The idea behind the checklist, as the fundamental idea, has been the empowerment of parents and carers, of knowing what to ask for and what to do. So any forum you go to, for example, the annual health check, I think I always had that on horizon. And many parents have said, I go to the annual health check, once his BMI has been checked, that's it. And it may not be focusing on the things that the parents want to focus on. So I would say, well, take this along to your annual health check. Ask your local health authority if you can use that as a guide when you are asking about the things that are concerning you, because there is evidence that they're important. And when you systematically rate them, they are important to you. So it's up to you really to take this forward and use it. To be empowered, I think, to ask for things that aren't usually considered, and to, as we're expected to look after our own health more, well, let's get good at it, and let's get good at asking for the right things. And I just want to ask Jane Waite now, I mean, anxiety, we know it's a very common problem in many people with intellectual disability and people who are autistic, but we know so little about it in people with more severe intellectual disability and those who can't communicate well. And Jane, can you give us a bit of an overview of your work in that area and the kind of things that you're finding or the questions that are around at the moment?
Yeah, completely. So, so yes, it's a really good point that we know so little about anxiety in people who have more severe intellectual disability. And partly that's due to a history of individuals who can't communicate using words being excluded from research looking at anxiety and mental health. As such, we know that there are very few assessment measures that can be used to screen people for mental health difficulties, particularly within clinical services, to make sure that individuals are getting onto the right pathways in the first place, to receive support with anxiety and low mood and other mental health difficulties. Part of what we're doing at Aston as part of the broader Cerebra network with Hayley Crawford as well at Warwick is developing a screening measure so that we can identify some of the behaviours that we see specifically in this population when people are experiencing anxiety, and being very careful to differentiate those behaviours from behaviours that we might see that are associated with pain or might be associated with autism spectrum disorder characteristics. So, for example, when we're interested in things such as when people avoid or withdraw from situations, there's lots of reasons why people might do that, but trying to understand and unpick which behaviours kind of hang together to identify, okay, so this looks more like anxiety versus this looks more like removing yourself from a situation because of a sensory sensitivity, or because simply that the person, it's a preference, the person doesn't want to be in a situation. And we're having to think very carefully about how we do that, because as Chris has identified in his presentation earlier, these things are also interlinked. So they're not, we can't completely separate them. We have to understand how they fit together so that we're in the best potential position to be able to identify those children that are more likely to have those mental health difficulties. We have a team of people working on that question at Aston. The other area that we're looking at the moment is whether we can adapt interventions that have been used successfully in people with moderate to mild intellectual disabilities, and typically developing children, for use with children who use few or no words, specifically to target anxiety. So we know that when people are anxious, they avoid situations, and some of working with anxiety and reducing anxiety means reducing some of that avoidance. But there are questions about how we do that ethically and how we do that well with people that can't necessarily tell us what they're experiencing. So we've been developing a parent-led intervention program that involves several weeks of working with parents to understand children's individual anxiety signatures, and then working in a specific situation that the child experiences to try to reduce anxiety, but with very much a sort of coaching approach to working alongside the family. So that's what we're currently doing. And Effie and Jess Hughes are working on that. And I don't know if Effie wants to say anything specifically about her experiences so far of working on that project and what she's learned from speaking with families about the anxiety that they report in their children. I'll just throw you on the spot. Effie, you there?
No, that's fine. Thank you. Yeah, so one of the things that we've been doing within this project is working with parents. So trying to design this intervention so that it is of most benefit to parents. So what gaps do they feel aren't being addressed when they approach clinical services? What strategies do they think would work? And I think one of the overwhelming responses that we got through these like focus groups with parents was that for individuals with severe to profound anxiety and intellectual disability, anxiety isn't well identified or well understood, and so there's a clear gap with these strategies that is needed. And so sort of some of the work that we're doing, parents do think that it would be really helpful. And so we're kind of really excited now that with our study, we are actually going to pilot if these strategies work and if they do work and parents still find them of benefit. And that's sort of one of the most important parts of this research is this collaboration with parents and making sure that we are addressing the gaps and this is most successful for them.
Yeah, I think that's always been, for me, one of the most impressive things about the work, I mean, across the Cerebra network, but in this instance at Aston University with Jane Waite and Effie, has been taking into account what is doable in an intervention. I mean, we can get interventions, we've seen them, delivered in the health service setting, but when you try and do those on a day-to-day basis, when you are sleep deprived, when someone's having a meltdown in the middle of Tesco's and so on, these are very, very difficult. So this collaboration with parents in moulding the type of intervention is really important. One of the things that we've sort of touched on a number of times, but we haven't really focused on, and you may think it's missing from our checklist, is autism. It's such a big question. And in people with more severe and profound intellectual disability, there's a real question about whether having a diagnosis of autism is helpful, whether it really informs us or tells us any more than we already know. And there's a bit of a question as well about how autism manifests in people with different genetic syndromes. And there's a program of research over the years been led by Joanna Moss, who's the fourth arm of the Cerebra network down at the University of Surrey. And I'm just going to ask Jo if she would comment on that and say a bit about autism and severe and profound intellectual disability, autism in syndromes, and whether this is, one of the most important issues. Over to you, Jo.
Thanks very much, Chris. Yeah, so we've been doing a lot of work looking at social behaviour more broadly across individuals with genetic syndromes, but with a bit of a focus on those autism characteristics and profiles of autism. And what we know is that in these groups, autism characteristics are very common, much more common than we might expect them to be. We also know that these autism characteristics are often present in a slightly different way to what we might expect to see in individuals with autism who don't have a genetic syndrome. And so this has been really important to highlight. One of the issues with these atypical profiles of autism is that this has a knock-on effect in the way in which we can effectively assess and diagnose autism in these populations. Often these characteristics are just not being picked up or not being recognised because they look a little bit different to what we might expect to see. So a lot of the work that we've been doing has been trying to highlight the importance of these characteristics and highlight the way in which they vary across different syndrome groups. We've also been looking into aspects of social cognition that might help us to understand the way in which these characteristics develop and to understand why these differences in autism presentations occur across these different groups. And that work has been led by Catherine Ellis and is going to be continued by Cerebra funded PhD Lauren Jenner, who's going to be looking at autism characteristics and social behaviour more broadly in individuals with Down syndrome and Prader-Willi syndrome as part of her PhD. And then the other aspect of this work is trying to really think about this issue of assessment and diagnosis. So looking at the sensitivity and validity of diagnostic assessment tools and how we can improve the use of these tools within this population. So that work is going to be led by Cerebra funded postdoc Natalie Bosilova, who's been doing some great work in getting us set up on that particular project. And then the final thing that I just wanted to mention is that we're going to be producing some training resources for educational practitioners that will be hopefully launched on the FIND website later this year. And that's going to be focused around identifying aspects of social difference in individuals in this population, and specifically around the importance of recognising and understanding those autism characteristics. And I'll leave it there because I can see people needing to head off.
Okay, thanks very much, Jo. Yeah, I just put a note, we come out to 11 o'clock, just put a quick note in the chat. Please give us some feedback on the checklist. We've had, it's been really helpful to hear people's comments. We will change it to make it better in the future and more, meet your needs. So I will stop now and I'll just hand back to Beverley Hitchcock at Cerebra and just thank everyone who's pitched in on answering the questions. Thanks, sir.